Hello to those coming in the virtual room. We're going to give it just a moment before we begin, but we're glad to see you here today. If you'd like, you're welcome to say hello in the chat. Let us know who you are and where you're coming from today. All lines are muted to prevent background noise, but we still would love to hear from you. Again, we'll give it just a moment so we can get a good number of folks in the room. We also will have some folks joining us after the fact when they watch the recording. All right, we will go ahead and get started. Again, hello and welcome to session 1 of our webinar series on caring for an aging population. My name is Ariel Mather and I'm the program manager of the National Center for Equitable Care for Elders. And again, we're so happy that you could join us today. If you're watching the recording, we're very glad you were able to access this information as well. If you're not familiar with our center, we provide training and technical assistance primarily to community health centers across the country and other community-based organizations. If you'd like to stay connected with us, all of the links are on this slide. Another great set of resources can be found on the Health Center Resource Clearinghouse. If you're not already familiar, there's a link on this slide. The slides have been made available right after this session, so you'll be able to access all of those resources. You can see that there's up-to-date information and resources related to COVID testing and therapeutics, as well as updated information on things like monkeypox. We're all very familiar with Zoom reminders by now, but just a reminder for today's session that everyone is muted to prevent background noise, but we would love to hear from you in the chat box. You can use that or the Q&A feature to ask a question of today's presenter, and we'll do our best to get to all questions by the end of the hour. We will send out a link to the recording of this session as soon as it's available, as well as the slides, like we mentioned, via email after this session. And when you close Zoom today, you will get a pop-up of a survey that we just need a minute or two of your time to give us some feedback on this session and any other topics you'd like to see in future webinars and learning activities. So we'd love to hear from you. So today's learning objectives, you were able to see when you signed up, but over the next 2 weeks, so today's session and next week on August 31st, we're going to understand the impact of the growing number of patients over the age of 65 on our healthcare system. We're going to learn about integrated and highly coordinated care and how that can benefit this population, and identify some age-friendly strategies, both within a healthcare setting and beyond. I'm very pleased to pass it over today to our speaker. Dr. Peter Marimaldi is our subject matter expert at our center related to social determinants of health and aging. He has positions at both Simmons University, the Harvard School of Public Health, and the Harvard School of Dental Medicine. And he's going to weave some of his background into his slides and his talk today. We're very excited to hear from him. So go ahead and take it away, Dr. Marimaldi.
Thank you, Ariel. Thank you very much. And thank you all for joining us today. It's really a pleasure to talk about something near and dear. And I'm going to start and ask, does the date January 1st, 2011 mean anything to you? It's something I heard about the first day I walked into graduate school in the 80s. And it was very interesting how it's been coming up again and again. But that was the day when 10,000 people a day started to turn 65 in the United States. Next slide, please, Ariel. And how did that all happen? Well, you know, there was this little war. World War I actually was a disaster when the veterans came home. There was a lot of social unrest. And what happened at the end of World War II, the federal government was prepared for the soldiers' return. And when the war ended, things were very uncertain in the world. Things could have gone either way if the Axis powers had won. But we came home victorious, the troops, and the government set up the GI Bill, opportunities for jobs, education, housing, and people began to procreate. And they procreated and procreated and procreated. Next slide, please, Ariel. And that gave rise to the baby boom generation. And we're still in the midst of the baby boom generation. You know, these pop statistics, every day somebody's turning 65. Just think of the implications of that. And you see it in your healthcare settings with Medicare recipients. If we look more closely at population distributions in the United States, this is some of the more recent data. What's interesting is we have to look past the baby boom generation. I'm going to talk about this a little bit more later in terms of the impact on national health expenditures. But if you look at the distribution, we have something we've never seen before, is we have an older generation living longer than expected. Life expectancy is increasing. And just in your own experience, how many of you know someone who's 100 years old or older? We hadn't have centenarians as many as we've had. We have more in the United States than other countries. The rate's lower, but we have centenarians now. And this is almost unprecedented. Next slide, please, Ariel. The other interesting thing, and in case you need to be sold on this, and many of you don't, but I think it's important if you're going to back, I read the registration, some of you are going to use this material for training. The 65 and older group is the largest, fastest growing segment of the population. And this is right from the Community Health Center chart book, which many of you, I'm sure you use it. If you haven't, I encourage you to check it out. There's some really great data. I'll show you some more from there shortly. But we've been talking about this population shift, and now we're really in the middle of it, and we're going to feel it a lot in healthcare. Next slide, please, Ariel. This is no surprise to those of you who are working in health centers, but it's an interesting mix. Medicare patients, that's 65 and older, eligible for Medicare health benefits, make up 9% of health center populations nationally. In some rural areas, it goes as high as 25%. And at the same time, 1 in 5 of the people seen in health centers are Medicaid beneficiaries. It's the intersection of these two that is really drawing interest from the private sector, because this is guaranteed payment from the federal government. So it's a different discussion, but I just want you to start thinking more, and many of you are working with what we call dual eligible populations. But in the past, our focus was, we were thinking more and more about baby boomers, but now we also have to think not just about the baby boomers, but the the people 85 and older. And I'll talk more about living with multiple chronic conditions. Next slide, please, Ariel. So let's think about this in terms of, how do you really count patients? Well, the data that's most reliable are expenditures. I mean, you can read this yourself, but the point is, if you look at the middle box here, Medicare is expected to experience the fastest spending growth. That's 7.6% per year up until 28. Now that could change, we don't know. But the other issue is in the last box here, and you all probably know this, but it's something to always keep in mind. If you're trying if you already have a very age-friendly health center or the context in which you work, there's always going to be naysayers. This is important information that you can pass on. But, it's 15% of the population is we consider older population, but they account for almost 35% of all spending in the most recent year where those data were available, which is 2014. Next slide, please, Ariel. And you all know this already, but health centers are much more likely than private practices to have patients with chronic conditions, and many with multiple chronic conditions. And the chronic conditions put an enormous strain. And this is where I'm going to be talking more about this wider view of these social determinants of health, the non-medical issues related to health. Next slide, please, Ariel. So these all probably look familiar to many of you. And this is what we're thinking about in terms of the types of chronic conditions. And you can see why some of those expenditures are so high. As you look at this, I think you can also see, and I'm going to talk more about integrated care, where integrated care can be so effective in addressing these kinds of chronic conditions to keep people working at the top of their license. Next slide, please, Ariel. Those of you who are, this is interesting data from Brookings, but if those of you who are working in non-urban areas, you can see that there's a real decline in what we define as major metro areas. But you can see it's the orange or brown or whatever you see that color as. with the increase, you can see that there's an increase of people, and this is domestic migration, people moving from within the United States to not other metro areas, but really the non-metro areas. So those of you in rural populations are likely seeing increases in your panel sizes and patient populations. I'm just asked my colleagues if there's anything coming up. I can't see the chats. If anything comes up in the chats you'd like me to address, just let me know, please. Next slide, please, Ariel. So let's shift now and talk about social determinants and social needs. So I'm going to define these. I'll use the WHO definition as non-medical factors that influence health outcomes. And if you look, you can read this slide yourself, but if you look closely, these are things that traditionally providers didn't spend a lot of time on, most providers, not all, didn't spend a lot of time thinking about. But increasingly, we've come to understand just how important all of this is. And, you know, being a clinician turned academician researcher, the clinician in me especially likes the next slide, because our old friend, next slide, please, Ariel. Abraham Maslow. Some of you may be old enough to remember the Maslow's hierarchy of needs, but in 1943, this was published, and it was discussed earlier in the early 40s. But if you look at this bottom rung of the pyramid here is what we now think about as social determinants of health, maybe the bottom two. But the idea here is that people need clothes, housing, food, health care before they can get to these higher levels of functioning. Now, a lot of people think this is quaint, but I took a deep dive in the literature, and it's very interesting how a lot of folks are referring back to Maslow's work, you know, from the 40s. Next slide, please, Ariel. And then we go further and we think about this. Now, this is taken, and this is public information. These are your cancer. It's from the National Cancer Institute, but it's your tax dollars at work. I use this slide a lot when I'm presenting to health providers, and I use it a lot in teaching as well, and training to a lesser degree. But I think it's very important, and it's a good reminder of this multi-level approach to epidemiology. And it's not just genetics or a physical condition. We look at risk factors. We look at social relationships. You see how these overlap with some of the earlier Maslow work? And this is a very, very important to consider this over the life course, because this is not static. This changes constantly. And none of these act alone. All of these are simultaneously interacting with each other. Next slide, please, Ariel. It's just another view of this, what we call the ecological perspective. Now, traditionally, when in the behavioral sciences, if you go back to the early days, and many of you remember the name Sigmund Freud, psychology, psychiatry was thinking about mind on mind. And we would treat people, their mental issues, their mental health issues, and their overall approach of well-being, mind on mind. But that changed. And what happened around the same time in the field of social work, for example, and public health, for example, we started to understand the importance of the environment. And you can look here at the different levels of environment that we call the ecology that the patients live in. And this ecological perspective dovetails very nicely with Urie Bronfenbrenner's systems theory. Many of you may have studied systems theory, where the idea is if you start on any given point and you trace out all the systems, you come up and you can do different levels, from a micro level to a meso level to a macro level. You can see that there's so much interrelatedness. It's just not me living in my home. It's everybody who's around me and everything that happens with me. It's just not me showing up in a physician's office, in a primary care clinic. It's everything that happened before the patient walked through the door of the primary care clinic. Think about how complicated that really is. And that's what makes it so, we make Meshuggah, we say in New York. That was so crazy that we get about these things. So I like to think about it this way. If you can just in your mind's eye, picture a very still body of water. And it's actually reflecting whatever's around it. And it's one of my favorite things to say. But if you just think about a very still body of water, then take up a handful of pea gravel, little tiny stones, and toss that into the water. And you see all these concentric rings. That's what the systems theory is all about. Throw one in first, and you just see it go out, then throw a bunch around it. And it's this constant interaction that makes it so complicated. And that's why, the next slide, please, Ariel. When we started talking, 15, 20 years ago, about going upstream, understanding why we wait so long to address issues that could have been circumvented earlier on, not just health issues, but also social issues. There was the remake of West Side Story, juvenile delinquency we talked about in 1968. Think about the preventive programs that might have kept those young people out of harm's way. So I worked, starting maybe, I guess, 7 years ago, started working with a group of leaders in the field of social work to develop something from the national academies. Now, I had been a consumer of IOM reports for my entire life. I had been a consumer then when it morphed into the National Academies of Science, Engineering, and Medicine. But I'd never really understood the mechanisms. To make a long story short, we brought forth a great deal of evidence about upstream interventions, about social determinants of health, about the non-medical issues that impact an individual's health and well-being. And we pitched the idea and were able to launch a consensus study on social needs. And this consensus study, we had to raise $1.2 million, and this is available to you. It's the publication, there's a toolkit, there's summaries of it. I would encourage you to take a look. The recommendations are not an end all, but it's something that's very important. I was one of the reviewers, the final reviewers on this. And I, like so many things, I said it's better than nothing, but it still needs more work. But I would encourage you to take a quick, if you can, if you haven't seen it already, to understand this. But what it means is, next slide, please, Ariel. Finally, social determinants of health, social needs have been accepted in mainstream medicine, nursing, and allied health professions. We've finally come to understand this. Now, the Affordable Care Act gave us tremendous opportunities to do preventive care, and to start thinking about those kinds of issues. It's easy, those of us who are old like me and have been around for 25 years, 30 years, it's easy to forget how hard it was to sell people on preventive care when we were back in the fee-for-service days. But now it's sort of the norm. Now, this is how the CDC presents social determinants of health. And it's important to understand, if you're just focusing on the top right quadrant there, the healthcare access and quality, I think of the triple aims when I think about all of that. But when you look at the healthcare, it's impossible to practice one without the other four, or whatever area you're in. So it's very important to understand that these are simultaneously constantly interacting. Think about systems theory, think about ecology, think about those pebbles in the still water. These are constantly interacting. So what I'd like to do today, when the National Center for Equitable Care for Elders asked me to do this, I thought about what would be an approach, something to think about. And I really think that a harm reduction approach is something that will help reduce ageism. And by eliminating ageism, it's a good way to start making age-friendly provision of healthcare. So if you go to the next slide, please, Ariel. Let's start with harm reduction. Many of you have worked or are working probably in harm reduction, but it was traditionally harm reduction. SAMHSA did a lot of work with this, but harm reduction was primarily thought about, and I guess in some circles still thought about, as a way to address substance use and to prevent substance misuse and to save life. But many of us now are starting to take the tenets of harm reduction and try to apply them in other areas. And I think it's a very effective way to go. And by definition here, I just grabbed this definition from a recent article. But it's the aims to reduce harms, usually stigmatized behavior. Think about aging. Who wants to be waiting for an old person to finish telling their story, or to take 5 minutes to walk through a threshold? Think about the kinds of things that may be annoying about old people to many folks. Stigmatized behaviors, and recognizing that by preventing them, we can, taking them away, those things would exacerbate harm. The literature is in ageism hurts people. I'm going to show you that in a second. But this idea of harm reduction strategies, just think of that, how that might work to make an age-friendly environment. And it's not just ageism, it's also eliminating steps, for example, or physical barriers that would prevent someone, or a toilet seat that's too low for someone to get off of independently without assistance. Little things like that, a raised toilet seat can make all the difference in the world in so many different settings. I think about curb cuts, what that's done for people with disabilities as well. Next slide, please, Ariel. So let's talk about ageism. Okay, so when I was a student in New York, Bob Butler told me whenever I ever talk about ageism for the rest of my career, to give him a nod. So there you go. Robert Butler coined the term ageism in 1968. And the original article is very interesting. It's in the Gerontologist, but it was during a period when we were starting to identify isms in the United States. And here's a lovely definition. But if you look at them for more contemporary use, I would direct you to the WHO definition, which you can read here. But what's important is how we think, feel, and act. And it's prejudice and discrimination against others based on age. Now, what's interesting about that is, and I just pulled this from one of the trade journals, how it works on the micro, meso, and macro levels. There's institutional ageism, there's interpersonal ageism, and it's internalized ageism. I'm going to show you some data about those as well in a slide or two. What's important to think about here, and it's some of the work that we're doing here in Boston, is we're thinking a lot about blind spots. And very, very well-intentioned people very often are not aware of their blind spots. And it's not uncommon in healthcare, in industries, elsewhere, to see where people, well, I love old people, but it's the eye roll, it's the sigh, it's the, oh no, how long is this going to take? I'm going to give you some examples of this. But to start thinking about, are we really as age friendly, and how much ageism is around us that we're not aware of? And there's data to support this. I can tell you my own daughter talks about how old people smell. I find it offensive, but I want to understand where she learned that and how she and her peer group talk about those things. Old people, and there's a literature on uncle, okay, uncle in the international literature, with a negative, very negative connotation. My colleague Gene Cohen, the late great Gene Cohen, who was one of the chairs of the National Institute of Mental Health, a psychiatrist, he did a review. We were on a project together for the National Library, the National Association of Libraries. And he did a review and found only 82 children's books. Think about how many children's books there are. 82 children's books that showed old people in a positive light. It's always the Wicked Witch, doing something evil, those sorts of things. But ageism is pervasive. And I would ask you to think about, when in your own facilities, is there a blind spot that you might be able to identify? And what can you do with that? Next slide, please, Ariel. So this is an interesting study, came out of Michigan. And it's a national poll on healthy aging. Just over 2,000 people were interviewed. It's a nationally representative sample of people between the age of 50 and 80. So if you look at this, 82% of the respondents said they experienced one or more forms of ageism in their day-to-day lives. That's very significant. Now, this is perception. But this is an older person thing. Yeah, I experienced ageism. 65 were exposed to ageist messaging, 45% interpersonal interactions. And this is what I find interesting, internalized ageism, where I would think of myself negatively because of my age. Next slide, please, Ariel. Interestingly, on the other side of the coin, these same respondents had very positive views on aging. And this is the difference between stereotypes about old people. On the earlier slide about boomers to zoomers, where they, they old Schwinn bicycles when they were kids, as children, and now as adult baby boomers, they don't want to stay home. They want to live in the community. They want to go kayaking. They want to go bicycling. They want to go hiking. They're very active. They typically, and I'm talking in generalities here, but people, think of themselves in this, again, this is a representative sample, it's a stratified sample of 88% felt comfortable being themselves, a strong sense of purpose, 80%, and more than half, almost two-thirds thought they felt positive about aging. And so many were surprised, more than half were surprised that their life was better today than they thought it would be. And that has a lot to do with what happens in healthcare. And that has a lot to do with what happens in age-friendly communities that help people age in place. I'm going to talk about those things as well. And let's go into the weeds a little bit on this survey. Next slide. I'll try not to take too much time on this, but I found this to be very, very interesting. The same survey with people who experienced 3 or more forms of ageism were less likely to perceive themselves to have good health. Again, 3 or more forms of ageism were more likely to have a chronic condition, and 3 or more forms of ageism respondents were less likely than those who had fewer forms to rate their mental health as excellent, and more likely to report symptoms of depression. More likely to report symptoms of depression. Is it the cause of depression? No. But is it a contributing factor? Maybe. But it's an interesting finding. Next slide, please, Ariel. Further, those of you, many of you, and since I grew up in New York City, and since I was a clinician, I've been trying to figure out culture my whole life, and I'm still trying to figure it out. I've studied it extensively. I spent 3 years at a psychological anthropology work group at Columbia University. I mean, we're still not there, but I think many of you have tremendous expertise in how to work across cultures. This cultural humility that we're talking about. We're constantly struggling with this. But this is from Health and Human Services web page, and there's a link here for it. But I don't know if any of you are working with, and I wish we had more interaction, I could see this, but if many of you are working with class, and it's about respect to the whole individual and response. Now, years ago, I did a training, a career development training at the Moffitt Cancer Institute in Florida, and we were talking about something that blew my mind because I thought it fit beautifully. And what it was, this notion of culturally and linguistically appropriate communications. And lo and behold, here it is now, I don't know, 22 years later on the HHS website. So, think about in your own settings, or your settings. So we used to think language was enough. Sometimes I hear people say now that language is a proxy for culture. I'm not sure if I agree with that, but maybe that's the closest we can get health settings. I know some of the large hospitals that I consult with are using that as a proxy for culture, but it's interesting to see. But the idea of tailoring services to cultural and language preferences, hard to do. But in a few slides, I'm going to show you something from IHI that may help you do that. And that's this. It's all about being applied. Next slide, please, Ariel. Okay. Caregivers. This is something near and dear to me. I buried both of my parents. I was a caregiver for 18 years. And one of my great interests when I'm traveling around the country, when I'm doing either research or consultations, I really enjoy speaking with caregivers. And that's why when this study was published, this is one of the many things that came out of COVID, and we often think about all the negative things that happened to COVID, but more, I don't know in your circles, but I know in mine, we're often talking about, we wouldn't be doing this now if it weren't for COVID. This is a study on the impact of caregiving during COVID. This is the primary source. If you're interested, it's free, you can download it. Next slide, please, Ariel. And here's a summary of some of the findings. And I found this staggering. 45% of caregivers between the ages of 24 and 43 had serious suicidal thoughts in the previous 30 days. Wow. This is at the time of the survey. 80% of Black non-Hispanic caregivers were experiencing adverse mental health symptoms. 80%. Are these caregivers? When we think about older people in your practice, or maybe I'm thinking of, I'm a gerontologist, I think of it from that angle, but maybe, you're thinking of it from, the adult population that you serve. Are you thinking about it as the caregivers, or are you thinking about the older people? As a gerontologist, I always wonder in your panel, do you have the caregivers of the patients, the geriatric patients that you're seeing? Because we have a shortage of gerontology clinics in this country. We know there's not a lot of, most of it's going to land in primary care. Most of these folks are going to land in your settings, unless you're in a gerontology setting, those sorts of things. So these kinds of findings I find staggering, and I hope you'll find them helpful. 91% of caregivers in high intensity caregiving situations overall had adverse, that's 9 out of 10 adverse mental health symptoms. And you can read on, the 70% reported at least one adverse mental health symptom during the pandemic. This includes anxiety, depression, and suicidal thoughts. Next slide, please, Ariel. I hate to read slides, but you can read these for yourself, but you get the picture here, that caregiving takes its toll. I interviewed, I can see this person in my mind as I'm speaking to you now, a gentleman in middle America who told me that he had to decide between his wife, his 2 children, or his mother with his free time, because he was working 2 jobs to pay the bills. And he chose his mother, and it's costing him his family. And tears were streaming down his eyes as he's telling me this. So and that's not the only, I can give you countless examples of this kind of dynamic. But this is why it's so important to share these kinds of data, if you're not sharing them already, with your colleagues, and see how we can do it. And I'm going to show you in a couple of slides some ways to do this. Next slide, please, Ariel. Now, this is something that's very, very interesting. It's coming into vogue. I've used this a lot in my practice, and when I did more clinical practice, and increasingly now I'm getting pulled more into doing using these kind of clinical tools and research. But if you this care mapping, I don't know if many of you are using care mapping already, but the idea is you have this schematic of let's say the elder. You put the elder in the center, and then you sit with the caregiver and say, who's doing what to help this elder remain in the community. And you draw these things out this way. And then what I love to do is say, okay, now let's put you on a piece of paper, and who's helping you. And typically there's a heck of a lot more ink on the elder's page than on the caregiver's page. And there's a terrific point of intervention. Next slide, please, Ariel. And that's where I'm going to take a commercial break, because if you really want to learn more about this, there's an excellent webinar coming up from the National Center here. You can, there's a link here on the webpage to register for this, or you'll be receiving emails from the team on this. But it's something, if you have time, on September 14th. Next slide, please. It's a great tool. Okay, now let's talk about near and dear integrated care. There's so much talk about integrated care. Many of you are expert in integrated care. My sense is the more expert one becomes in integrated care, the more one wants more integrated care. And Don Barrick's quote here, I think is so appropriate. When integration is lacking, patients are lost, activities don't take place or are delayed. This is where medical errors occur. And with aging populations, this is especially true. And it's most blatant when we think about someone who's being seen in a primary care clinic. They have an acute event, they go to an emergency room, they get discharged from the emergency room, and who knows what happened in the emergency room. Does it get transferred in the record? Who knows? What about polypharm? How is that affected during those kinds of episodes? Same thing with specialists. I can't tell you how many elders, 85 and older, I've interviewed who talk about how confusing it is for them when they're seeing a specialist for one of their 5 chronic conditions. And every time they go, they have to tell their story over and over again because there's no communication between the specializations and the primary care. We're getting better at this, but we still have a long way to go. Then ask yourself, do you have the structure for integration? And by structure, do you have the facilities? And do you have the workforce necessary for integration? There's always more, but some's better than none. And then do you have the process for integration? Now, we dreamed years ago, not too many years ago, that the electronic health record would help with this process. And I think in many situations it is, but it's not everything. Then we come down to the issue. Are you seeing, what's more important, the screen or the stethoscope? I mean, we have these debates now as well. So it's, do you have the process needed for integration? And by process, this is about communication and the time accommodations for older adults. Interviewing providers, primary care providers, about their work with older adults, universally, one of the things that comes out is the time demands. Because not only does it take longer to sit and talk and work with an older adult, typically, not always typically, but very often then the phone rings and someone wants to talk, a caregiver wants to know what's going on, how the visit went. And this is where integration comes in. Next slide, please, Ariel. So this is an idea. It's sort of a culmination from the literature and from my own personal experiences, optimizing care delivery for older adults. So I don't know if you like the term top of the license, optimal, whatever, but I mean, there's a literature emerging that, and one of the questions I like to ask, what do you love about your work? To clinicians across the gamut, and all the way from receptionists to the top person in a given setting. What do you love about your work? And very often, what they love about their work is when they're working to their optimal capacity, top of the license or function. And are we keeping people working at that level? And if we're not, how can we help? I mean, one of the early examples was managing chronic diabetes, chronic blood pressure. You didn't need the primary care physician or the PA or the NP to be doing that when someone else could be taking readings. And was that appropriate? And we still debate that. But then the whole thing about this maximized team-based care from receptionists to primary care providers. We published a paper years ago about in oncology about the person very often who had the most information about the families was the receptionist, because the receptionist spent the most time with the patients in the small waiting room and they chatted. And it was the title of the article was The Forgotten Team Member. And when patients died, the team took care of itself, but they forgot about the receptionist who had a strong personal relationship. So I think that I use that as a reminder very often when I'm observing or visiting settings. How team-based is this and who's included in the team, which lends itself to, are the caregivers or information from the caregivers included in the team? Now, people say it's pie in the sky, we can't bring it, but we do that. We have case conferences, we have family members sit in when we meet with the patient and do things. Typically in aging, but this is, there's got to be accommodation for this. There's some billing codes, but it takes a lot of time. So do we include them, caregivers, especially when we're talking about treatment planning, given the fact that the caregivers are going to take the lion's share? And the last box on the bottom here, I'm going to talk more about, but this ongoing development of community partnerships that facilitate aging in place is absolutely critical. You know, it's an ounce of prevention, just a little time contacting people in the community, a church group, a synagogue, a mosque, a civic organization, things that will help just with respite, for example. Next slide, please, Ariel. So I'd like to shift now and talk about this age-friendly health systems. And this is an initiative from the Hartford Foundation with the American Hospital Association and the Catholic Health Association. They talked about age-friendly systems aimed to use best evidence-based practices. Next slide, please, Ariel. And the idea here is what matters. And this is the 4 M's. And this is readily accessible. It's extensively researched. They have fantastic resources on the IHI webpage. If you are already using them, I'd be interested to hear what your experiences are. If you're not using them, I'd be interested to hear what you think about it. And on the follow-up webinar from today, next week at this time, we have 2 guest speakers who will be speaking extensively about the 4 M's and the use of the 4 M's. But very quickly, what matters, and that's the linchpin. When you think about things, again, back to the stones in the still pond and all those systems moving around, how to figure this all out. Asking the patient what matters is brilliant. What's most important to you? And that is often one of the most valuable, but also one of the most difficult. And on the IHI webpage, they actually did a whole supplement on how to interview patients, to talk to patients about what matters. You learn a lot more about that next week. So again, the 4 M's, medication. I don't have to convince any of you, I'm sure, about how complicated polypharmacy is and the potential for medical errors therein. You know, and especially with older populations. I know in my own learning, my father was when he was alive, after his wife, my mother's death, became very depressed. So I moved Earth to get him into a geropsychiatrist to prescribe medication that was working very effectively. And guess what? I came home one time and my dad wasn't feeling. I said, "Dad, what's going on? You taking your medications?" They were doing so. You're doing so well with that. He was doing one every other day or cutting them in half. I mean, you've all heard this. It's ridiculous, but it's thanks to for putting that up. And what it is it takes a lot to follow medication. Now, some of the best clinics that I visit have a pharmacist on site, but that's a lot of money and that's a lot of resources. But a pharmacist is a terrific addition to a team. Mentation, treat, manage dementia, depression, mental health issues. But it's really important to understand the difference between delirium and dementia, because delirium is temporary and reversible, as you well know. But do people really look for that? Or is it easier just to chalk it off as dementia? This may happen more in inpatient settings, but we see it a lot in primary care as well. And again, this is why it's so important to have this aging lens on. And mobility. And for me, mobility includes just being able to get in and out of the clinic or wherever they want to go, including social interactions. Next slide, please, Ariel. And here's evidence, a recent article for the 4 M's. And it's an interesting read for those of you who want to take a deep dive into the 4 M's. I highly recommend this. Next slide, Ariel. So the idea is that this is all evidence-based. And in the IHA guide, there's a practice setting in a hospital setting. And we're going to, again, you're going to hear a lot more about this next week, but in the practice setting, what's so critical is to understand, just like with social determinants, you can't do one without the other. you've got to address all four at the same time. These do not occur independently. And to take, this narrow view, this is the negative side of Maslow's theory. It's Abraham Maslow. You've ever heard the the law of the hammer. If you have a hammer, everything needs to be hammered. If I'm a psychologist, it doesn't mean that everything needs psychology. It means psychology is part of everything else. If I'm a medical provider, medicine is part of everything else. And that's why it's so important to remember that these are practiced as a set. Okay, now let's talk about age-friendly. Next slide, please, Ariel. As I alluded to earlier, we used to have to sell people on upstream interventions, and the Affordable Care Act provided opportunities and resources to do preventive care. But what's happening now, it's thrilling. There's such an opportunity. So if you take a quick look here, the New York Academy of Medicine, in 2010, thereabouts, tried to make neighborhoods in New York City age-friendly. And they were working a lot with WHO initiatives on age-friendly environments. And you can see what they came up with. And I don't know if you can probably see this, but little things that you can do to help people remain in their homes. Grab bars. When I was a practicing clinician, I can't tell you, as a public health social worker, I did home visits all over the 5 boroughs of New York City. We installed tens of thousands of grab bars that kept people in their home. And many of you are doing this now, but what's not on here, I don't see it, handles, no. The raised toilet seats I mentioned earlier. Again, tens of thousands of raised toilet seats. It's not my area. I worked with an OT on that, but you bring an OT in and they're brilliant on how they can help you keep somebody at home. So I noticed on the sign up, there's folks from Rush here. Rush did this terrific program in Chicago, training first responders to look for fall hazards when they went into people's homes. These kinds of creative ideas and interventions to get people on board to start thinking about this. What would make this age friendly? But it's, again, everything's interactive. It just can't be piecemeal. It can't be siloed. Everybody has to work on this. The NIA webpage then reflects a lot of this about reducing ageism and making age-friendly environments. And it's a culmination of the work that was done 15 years ago, 10 years ago. But again, you've seen that it's made its way to the federal web pages. And there's some I love these fact sheets, but 1 in 3 volunteers is 55 years or older. That's a huge contribution. And you can look more closely at these if you want. Now, what I find especially interesting is how the private sector is moving in. I've visited a lot of private sector aging primary care clinics around the country. And what I find fascinating is how effectively private equity is targeting dual eligibles, to the point where they'll use all the tools of community organizing to get people into primary care clinics. Identify a neighborhood with dual eligibles, find a strip mall location. This is common now, and set up a primary health clinic, and in maybe 2 storefronts. One storefront would be a warming center or a cooling center in the summer. Have some sort of activities there. They would serve decaf coffee, as I understand it, every place I've been. But the idea is to get people in, and then perhaps they'll sign up for primary care in those settings. This is from Fidelity, and it's for people with means. But the idea is to have 6 success factors to help you age in place. So one of the key things about aging in place is what you do in health centers in your health context. Next slide, please, Ariel. So let's take a quick look here. This is WHO, and it's the notion of age-friendly environments. And environments play an important role in determining physical and mental capacity across the life course. How well people adjust to the loss of function and other adversity, particularly later in life. Loss of function, does that mean they lose their souls? Absolutely not. Think about that Michigan survey. More than 80% of the respondents felt good about aging. They may not be able to move the way they used to, but they sure as heck feel good about aging. And then the other idea is both older people and the environments in which they live in diverse, dynamic, and changing in interaction with each other. There's incredible potential for enabling healthy aging. And that's what we want to try to do. And I think that health centers play a key role. Next slide, please, Ariel. Here's some examples. Seattle. This is taken, if you went into that WHO webpage, these are the 8 domains of livability for age-friendly, and you can see it. You can read these for yourself, but geez, doesn't this look familiar to some of the things that we've been talking about in the environmental perspective, the ecology, the systems theory, the social determinants of health? See how it's all starting to just overlap? It's just great. But how much of it are we able to bring into primary care? How much of it are you able to bring into your health center? Is, the National Center for Equitable Care for Elders here and did a webinar series on social isolation and loneliness and the negative impact that had, especially during COVID. Well, they did it before COVID, but the negative impact that has and how important that is that's part of a treatment plan. Next slide, please, Ariel. Here's another example. Louisville, Kentucky, age-friendly Louisville. I noticed there's folks here from Louisville, and it's a terrific. This is a follow-up report to efforts that have been occurring for a decade earlier. And there's a real investment here. And what can we do as health providers to contribute to this or to initiate this? Next slide, please, Ariel. Same thing here for DC, age-friendly Washington, DC. And again, it's the age-friendly movement. This is the mayor making ground here. Next slide, please, Ariel. Those of you in rural areas, I'm sure you're familiar with the Rural Health Information Hub. This is a terrific resource. Some of the material on their websites is a little dated, but it's terrific material. If you haven't, I highly recommend that you take a look. But this idea of designing age-friendly communities. Next slide, please, Ariel. And here in Massachusetts, this is an initiative I worked on some years back with an amazing team. There's this Massachusetts Healthy Aging Collaborative. Very often these things depend upon who's in political office, who the players are, who's placed in departments of public health, how the government, the state government structured. But one of the big issues here is the notion of age and dementia friendly integration. And here's a little toolkit. You can look at it if you don't have it in your state, but I'm going to show you some resources, some links here to find resources in your own state. But dementia doesn't mean that somebody's dead. Dementia means that somebody needs a little bit of extra help or care, and we'll try to keep them as independent as we can for as long as we can. Next slide, please, Ariel. And again, resources from the National Institute on Aging, terrific resource. You can go in here if you're looking for ideas, if you haven't seen this already. Next slide, please, Ariel. And here's a couple of, I think there's 3 pages here. I'm going to show you where to find resources. This is from an NGO, nonprofit, Dementia Friendly America. And if you go to their website, you can click into community toolkits. They also have a way to find people who are doing some dementia work in your area. If somebody's doing it already, and you haven't been involved, maybe you can get in contact. And if not, you can try to develop something on your own in all your free time. I understand that too. Next slide, please. Here's the AAA's, Area Agencies on Aging. This is a terrific locator. It's from the Administration for Community Living. Very, very quick and easy way to find what's available in your own region, in your own state. Next slide, please, Ariel. And the Centers for Independent Living, which focus on independent living, providing independent living services for people with disabilities. There's a lot of overlap here. So with that, I'd like to just stop and ask if you have any questions. Are there things that came up in the chat that I missed? I thank you all very much for your attention.
Thank you so much, Dr. Marimaldi. We do have several questions, and I know we just have about 5 minutes, so we can see how many we can get to. We are looking forward to gathering again next week. So if there are ones we can't get to today, we can follow up during the second session. So we did have a question on intersectionality when it comes to aging and ageism. So I'd love to hear from you, Dr. Marimaldi, your thoughts on whether some people may experience more or harsher forms of ageism based on other factors like race, ethnicity, class, etc.
Yes, yes, yes. Yes to all of the above. And one of the more blatant discriminatory situations is when someone is both aging and disabled and has a different appearance than the people in the environment around them, or a different language. So I think it's a terrific question that we could do an entire webinar on.
Sure.
I'm sure that's an inadequate answer, but yes is the answer.
Mm-hmm. Yeah, we have quite a few questions that are kind of in that same realm. So those that are living with multiple chronic health conditions, are they more likely to experience ageism as a consequence of that?
Yes.
Is ageism affected by culture specifically? So the different cultures' views on aging and deferring more to elders and kind of looking at those differences in perception of aging.
I'll respond to that very quickly, and I'll use the US as an example. Oh, isn't she wonderful? She's 101 years old and she lives all by herself in that house. And she goes upstairs every night to go to bed. And she goes downstairs into the basement to do the laundry 2 times a week. Isn't that wonderful? It's that rugged individualism, as opposed to, and there's a cultural value, as opposed to a gerontocracy, where elders are to be revered and cared for and held in the highest regard. And you see that in different types of cultures and even within some US culture. But again, that's a longer discussion.
Sure. And the last question we can focus on today, I think, Dr. Marimaldi, and one of the graphics we had towards the end did mention transportation, but we haven't talked a lot about it in this particular session. But we have a question around talking about transportation as a social determinant of health, which it certainly is, but how can our approach to older adult transportation potentially have some ageism baked in there, and what can we do to make sure it's not?
What a great question. It takes dollars to make sure it's not. A young person wants to get to the doctor's office, they would take an Uber, maybe. Can an older person use an Uber? I mean, I did this once in a large, I won't say where, in a different part of the United States, went from the parking lot. I walked from where the public transportation for elders dropped people off, and it took me 17 minutes, able-bodied walking, to get to the clinic. And I talked to the patients, and it took them between an hour and a half and 3 hours to get to the hospital because the bus made so many stops. So yeah, there's a lot of room for improvement. And I think that individuals in their own settings would know best what needs to be addressed, and then to start some strong advocacy.
Sure. Well, I know we're just about at time. We did have a quick question around mental health issues for caregivers. I think primarily some of those stats are coming from those who are, whether it's a full-time job for them or not, staying at home and providing the caregiving, but the role of being an informal caregiver, I do think, contributes to some of the mental health concerns they may be reporting, but we can dive in a little bit more to that next week. You'll see on the slide that we'll be having our second and final session of this series on Wednesday, August 31st. Like Dr. Marimaldi mentioned, we have 2 fantastic panelists who are coming from health centers that have implemented an age-friendly framework within their health system. And it'll be really interesting to talk about implementation and any promising practices they have to share. For those who may be interested in that, I think it'll be great to hear some real life examples and talk about the partners they've worked with along the way. So again, we'd appreciate your feedback if you take a moment or two to fill out the evaluation survey that's going to pop up on your screen when you close out of Zoom. And with that, we'll wrap up for today. Thank you for your time. And thank you so much, Dr. Marimaldi, for your expertise. We'll see you very soon. Take care.